Okay. Hello, lovely to see you. Open your screen, your cameras up and let us see you. Welcome to our March webinar. Can you believe we're in March, everyone? We are so delighted to have some guests here from MGH Institute of Health Professions, and I'm going to let them introduce themselves. But before we get started, my name is Andra Davis, and I am part of a Cambia Health Foundation supported grant that is allowing, many of you have been here before, us to have these monthly webinars to support schools of nursing as they integrate palliative care education into their programs. So we have a really special topic today around fostering compassion and belonging in palliative care nursing education through use of language. And some of us may have some background in this through adjacent sort of topics, but this is so exciting to hear from them. And I am going to turn it over to those folks. And while they get started, would all of you, we'd love to just have you put in the chat where you're joining us from. And if this is your first webinar, we'd love to welcome you. Okay, with that, I'm going to mute.
Thanks, Andrea. Hi, everyone. My name is Rachael Salguero. My pronouns are she and her, and I'm so excited to be here with my colleagues, Dr. Alex Wolf and Julika Wocial. And this is something that we've sort of been working on for a couple of years now, and that we have a lot of fun with at school. We all teach in the pre-licensure nursing program, and we try to make the skits in our classroom. So we're really excited that you all have welcomed us here so we can present this to you. And we are all in Boston, Massachusetts, where we thought we had some spring last week. We all got a little taste of some nice weather, but now it is back to being freezing again. So for all of you in other parts of the country, I hope it's nice and warm. But we do not have any conflicts of interest. This is all, everything that we have in this presentation are things that the three of us, feel very passionate about and excited to share with you. So as I said, my name is Rachael, and my primary role is I am an assistant professor at the MGH Institute of Health Professions, and I teach a med-surg course and a pre-licensure nursing program, and I work clinically at Massachusetts General Hospital in Boston.
Hi, everyone. My name is Julika Wocial, and I also work clinically at Tufts Medical Center, and I also work as faculty at MGH IHP alongside Rachael and Alex.
Pretty sure Yulika's like right down the hall from me right now. It's really nice to see everybody. I'm Alex Wolf. My pronouns are he, him, his, and I am an assistant professor here at the MGH IHP. I also practice as a palliative care nurse practitioner at Mass General Hospital. And I also teach LNET courses, and so it really is very special and very much an honor for me to get to present in this webinar for the LNEC faculty for the LNEC Faculty Corner. So thanks for having us.
Okay, we do have a few objectives today. We won't read these out to everyone, but we are hoping that by the end of the presentation today that you are feeling comfortable with calling in and calling out, understanding the role of our role as either faculty or nurses in home care, bedside, outpatient clinics, to really support that supportive learning environment. And then for all of us that are in the faculty role, that you learn some skills. Hopefully you can walk away today with a few things in your toolbox, whether it's maybe changing your syllabus or something that you do at the beginning of class in your courses.
So now we're going to do a quick audience participation. We want to make sure that this presentation is interactive for you and you're not too bored for the next hour. So you might be familiar with Slido, but if not, it's pretty straightforward. You can either go to this website, slido.com, on your browser or on your phone, or if it's easier for you, you can just open your phone camera and scan this QR code, and you should be able to get to a screen that is asking you for a passcode or which is LNEC, all capital letters, and it is visible right here on the left-hand side. So once you type it in, you should be able to see this question. And we were just wondering if you could share with us in a few words or in a sentence, what does belonging mean to you? And as you type in your answer, I'm going to start reading through them, but you can just keep on typing them and they'll just be showing up on the screen as you go. If you have questions about how to get there, you can just put it in the chat and my colleagues can help you out. So being heard, being a part of something that resonates with my authentic self, being part of people care. Oops, sorry. Being part of a community that supports each other, a feeling of connection, being a part of feeling accepted or valued, being understood. So it seems to be like some of the themes here are accepted, valued, understood, connection, being in a group who accepts me for who I am, people who care about what I have to say. Some of the first ones, having a seat at the table, being seen, feeling safe, feeling included. Perfect. Thank you. Thank you so much. So it seems like acceptance, inclusion, feeling heard and seen are some of the themes that we see here. Thank you for sharing that. And now we're going to do a quick skit. So we're going to play 3 students who are entering a BSM program. So we're just asking you to listen to this skit carefully from a perspective of belonging.
And as you can see from our Zoom backgrounds, we are all hanging out in a classroom. We've gotten creative with our images. Hi, what's your name? Are you Alex and Julika?
It's pronounced Julika. Is this the
Oh,
pathophysiology class in here? I don't know if I'm in the right room.
I think so. I don't
Okay.
know. This is what I think I saw on my handout.
Yeah, that's what I
Okay.
saw. I think this is it.
Are you in the same program? I'm so nervous. I am. Are you in the program with me, in the nursing
Crap,
program?
sorry, I'm just making sure I had the right textbook. I'm glad I got the right textbook too.
Oh,
Sorry, what did you say, Yulika?
Yeah, I'm. My name is Julika, by the way. I'm sorry. I don't think that we already had a chance to introduce ourselves, and I'm sorry. I'm just so nervous because I've been out of school for so long, and my English is not really that good, and I just don't know if I'm gonna do well in this program. And anyway, it's nice meeting you.
Oh, you too. Well, I'm so glad I met you because I'm really nervous too. I've been out of high school for a long time and I'm the first person in my family to go to college and I'm really nervous. I thought I was going to be the oldest person in this program.
No, I've been out of school for like 20 years, Rachel.
Oh,
So don't worry.
okay. Oh, good. So good to
I'm glad, honestly, I'm glad to meet both of you because I think we're all it seems like maybe we're all going to be the old folks in the class because my partner and I just had a kid and we just moved here from across the country to we moved here to start this program and I don't know, like our baby is only like 8 weeks old this week and I don't know, I keep wondering if this is even the right time for me to start nursing school, but here we are, so I'm gonna just
Oh,
do the best I
wow.
can.
Yeah, I know. I thought that was going to be like what's the saying, the odd one out or something like that. I don't know.
Yeah.
I kind of feel like I don't know if I would belong here, but I guess we'll see.
well, well, so glad I ran into you all. It was fate.
Yeah, well, good luck, everyone.
Yep,
You
see you around.
too. Okay, so I know that might seem a little cheesy, doing that sort of scene, but we thought that that was important to show because, you know, it's part of human nature. We all want to belong. And I think anytime we go somewhere new, we start something new, whether it's a new job, a new program, we all want to feel like we fit in. And I think for all of us that are in education, or maybe you are working clinically in the hospital setting, and new people are starting all the time, there is that feeling deep down, that is, and will I know someone there? Will I fit in? Will I be the oldest person? Am I the only person, that hasn't been to college yet? Am I the only one that has a child? All of those thoughts sort of go through all of our heads all the time. So when we think about belonging, though, I always joke with my students and say, pre-nursing, you likely took a psychology class and you may have seen Maslow's triangle and thought, you know what, I will never have to look at this again. Well, here we are again. We know that the very bottom, things like air, water, food, and shelter are things that we need to survive. But then really only 2 tiers above that, we see love and belonging. So Maslow really had it right in, 1943, knowing how important it was to belong. So this is just a quick framework here, just to remind everyone of that importance of belonging. Next slide, please. So, as I said, this is part of human nature, whether, some of us may wear it on our sleeve more than others, but, really wanting to belong is a fundamental part of being a human being, regardless of anyone's culture or their language or where they grew up, or, any of their life experiences. It's a really, it's necessary for us to survive and to feel like we are part of a team or part of a program. And one thing that we know about our students when we look at the research, and this is, regardless of whether it's a nursing program or, any sort of educational background, our students are so much more willing to learn and want to participate in class, not only in class, but also at the clinical setting if they feel that they belong there. And this is so important. I think about sometimes my time in nursing school many, many years ago. I've been a nurse now 16 years. And I think about, sort of the expectations of, showing up to clinical and exactly sort of how you had to look and how you had to be prepared. And now I think we've come a long way with sort of, accepting other people's personalities, and, accepting other cultural backgrounds. But we still do have a long way to go as well. So our hope today is that when you leave this presentation, that as educators, whether it's in the classroom setting, clinical setting, outpatient setting, wherever your role is, that you have a better understanding of how we can make people feel that they belong and that they really deserve someone put in the poll, feeling like I have a seat at the table. And I love that because that's what we want our students to feel like. We want people to come in and say, you know what, I belong here and I'm supposed to be here.
So now we have another participation part for you, for our audience, and you can just go back to the same slide if you still have it up, or if not, you can just rescan it with your phone or go back to that website. And the next question that we have is if you could share with us, how do you make your students or your patients, depending on where you work, feel like they belong? If you have any strategies or any tips or any ways that you're already using? I'm just going to start reading some. Try to talk to them on a personal level, get to know them. It's perfect. Establish classroom agreements, help connect them to other students. Yes, that's very important. We do that too. Learn about their backgrounds. I ask and listen to their wants and goals for a class. So speak their names. Yes, I try to do that too because I'm not good with remembering names, so that always helps. We do groups of siblings as an icebreaker for students. Inclusive language, establish support within the classroom. They made it this far, they can make it. Exactly. Smile and have open body posture. Perfect. Establish trust with follow-up on needs, introductions, open-ended questions, learn how to pronounce names. weekly icebreakers, and reflection. These are some great ideas. We'll definitely save those for the future. Greet them by name, listen to them, always have a smile, show up early, and greet everyone. Yes, perfect. Well, thank you very much for sharing those with us.
One thing I was taken away from a lot of what people were writing is that some of the best ways to promote belonging in the classroom are pretty simple. And I think that's what we're going to talk about a lot today. We're going to spend some time just sharing a few practices that we've incorporated into our teaching in our accelerated BSN program at the MGH IHP. The first practice that we wanted to share with you, it's a very simple practice called the language tip that Rachael and Julika actually started doing, I think a couple of years ago. And then they taught me about it when I came to the IHP. And I just thought it was so simple, yet such a great teaching tool and a great way to promote inclusion and belonging in the classroom. So the language tip is actually just what it sounds like. It's just a small chunk of teaching focused on making the language we use as nurses more compassionate and more inclusive. Next slide, please. So the purpose of the language tip is to get students to think about the language we use to talk about health, to talk about illness, and even to talk about death. And how that relates, how that language relates to our attitudes and behaviors in practice as nurses. The idea of the language tip is not to be self-righteous, to be heavy-handed. The fact is, we all make mistakes, and we should try to learn from them, and our language should evolve. The language tip really gives us some space and some time to share things that we've learned in our own careers, and also to share resources and relevant research that informs the way that we communicate. So our hope is that even with with even the littlest, simplest things like the language tip, we can create more inclusive and compassionate, a more inclusive and compassionate learning environment for our students, and that they in turn can carry these practices forward in their practice. So the language tip is often presented at the beginning of class, and this can be a great way to engage students in the material, get them thinking, rather than just jumping right into a long lecture. We've also embedded a language tip within lectures and also on virtual and in-person learning activities. Some tips are a little more focused on specific language to avoid, or sometimes language to use. So a good example of that would be, you can see there, it talks about problematic labels that we sometimes inadvertently put on patients, referring to patients as a smoker, referring to patients as diabetic instead of a person with diabetes, or referring to a patient as obese. On the other hand, we also talk about the nuances of disability first versus person first language. There are plenty of instances in which patients may feel that their illness or their disability is very much intertwined with their personhood, and they may very well want to refer to themselves as diabetic or autistic, for example, and being able to communicate directly with patients to ascertain how they want us to talk about that. That's something that we discuss during class. And then, another example, the language tip really gives us an efficient way to incorporate palliative care topics like serious illness communication into our learning activities. So, talking about things like withdrawal of care and how jarring that can be. That's going to come up a little bit later. But withdrawal of life-sustaining treatment, transitioning to comfort care versus withdrawal of care. These are just examples of some of the language tips we talk about. Next slide, please.
I just wanted to add here really, really quick. I was just speaking of the person first versus disability first language. I was just flying back from Florida last week, and the pilot got on the speaker and announced to the entire plane that there is a peanut allergy on board and to please refrain from eating peanuts. And I just thought to myself that this person probably feels so bad for, not allowing anybody to eat peanuts, which there's like not much else to eat on the plane anyway. And now they are being called a peanut allergy versus like very depersonalized, right? Versus a person with allergies or something like that. So I thought about this slide, Alex.
Yeah, no, and one thing I thought of too, Dan asked a good question there about the term, what's an appropriate alternative to the term smoker. And, I remember being a young nurse and I'm doing like an admissions assessment on a patient in the ICU and going through their social history. And I remember asking patients, are you a smoker? And I give that example during class that remember, this is not just me saying you shouldn't do this. I've made mistakes too. I still make mistakes. And, so one of the examples I give in class is, we'll ask like, what's a better way to talk about that? And one of the things that a student actually suggested was asking the patient's permission, saying something like, "Is it okay if I ask you about your smoking history?" And how much different, first of all, how much more non-judgmental that is, and how much more compassionate it is to ask it that way. I thought that was brilliant. So that's one suggestion. So this is just an example of what a language tip actually looks like during class. So this one was all about the language we use to describe patients' subjective history. This might look familiar to you from like an electronic medical record, or even just the way we sometimes talk about patients. You'll sometimes see language, even sometimes in things like case studies, you'll see language like the client is complaining of 10 out of 10 pain due to a headache. And the subtext there is what? The subtext there is that the patient is a complainer, right? That the patient has trouble coping. When the more objective way, the more objective way to describe that subjective complaint is that the patient is reporting 10 out of 10 pain. Similarly, chief complaint, the client claims they took their blood pressure medicine this morning. Those are the types of things that we'll take a few seconds at the beginning of class to do as a language tip and say, what's the subtext here? What's really underlying? When we say client claims this, the subtext there is that we're not really sure they know what they're talking about, or they might not be telling the truth. No, the client reports that that they took their blood pressure medicine this morning. So this is just an example of what a language tip can look like.
Hey, thank you, Alex. And when I was looking in the Slido poll, there were lots of, I love how people were saying learn to pronounce their students' names. And I think back to my very first semester teaching clinical, and I still remember, I had a student with, for me, it was hard for me to learn, to remember and to pronounce it. And I remember asking her, do you have a nickname? And I think back to that experience and it makes me want to just, crawl out of my skin because I want to find her now and apologize. So, I think you're right, Alex, I think our students really appreciate when we sort of say like, we are so not perfect and we make these mistakes all the time. And, that's really helped us sort of foster that relationship with our students. So I'm going to just quickly talk about something called the difference between calling in and calling out. And I will actually put a link in the chat. Harvard has an incredible little website here that sort of like talks about the difference between calling in and calling out. And this actually all sort of spurred from I was called in by a student many years ago when I was teaching endocrine. I was teaching about diabetes, and throughout my entire lecture, I had practice NCLEX questions, that would say things like a diabetic is coming in, with signs and symptoms of DKA, for example. What do you do first? And the student after class came to me and said, I have diabetes, I have type 1 diabetes. And, just using that terminology diabetic throughout the lecture sort of made me feel like I was more of a disease and not a person. And that's really sort of what spurred my interest in sort of researching some other ways that, I could reframe my language. So calling in is more of a small group or a one-to-one conversation where we believe, as the person that whoever we're speaking to is receptive to learning. So, if we say like, hey, Alex, I'm wondering if we can talk about, what just happened. I sort of have that feeling that Alex is going to be open to listening to me and open to change. It really helps us foster that belonging when we normalize it. Whereas calling out is the opposite. So that's sort of what we think about, probably day to day, sort of has that negative connotation to it, like, oh, I was called out today or something like that. It's more of, a larger group, public attention. Maybe someone has already tried calling in, and, those attempts have been unsuccessful, or the person feels like there's a huge urgency, or they feel unsafe. So a few examples, when we try to coordinate our language tips to the topics of, lecture that we're teaching. So, for example, Julika is teaching cardiac next week, and I didn't realize it, but I did. She said, "You took my," joking. I took her language tip that went with heart failure of a frequent flyer, because we think about, a lot of times, not always, but our patients that have heart failure may, have lots of admissions. And so if we think, if someone says, oh, you'll recognize him, he's a frequent flyer, he's here all the time, we just think about how that patient might feel, or their family or their friends, if they're sort of being labeled as a frequent flyer. So a way that we could call in someone is saying, I heard you say the patient's a frequent flyer to the hospital. I'm wondering why you think that's the case. And then we always want to give, everyone the benefit of the doubt, and we want to give people that ability to, say what they mean. And what we know that is, most of the time people don't mean it, right? We accidentally say these things. I'm caught, all the time. I feel like I'm always learning words that I need to learn how to reframe. And so we could say a more inclusive way is to describe, that this patient's at an increased risk for admission. And really saying why. Is it because, they aren't sure how to take their Lasix at home? Or, is it because they don't have a scale and they're not weighing themselves every day, to know, how are they doing sort of fluid wise? And then I think the next slide, I have another, okay. So she's a drug seeker and only came to the ER because she could not find any on the street. So we definitely, for those of us that are working in clinical practice, we may hear this all the time. So thinking about some other ways that we can reframe that are, an inclusive way is, to say the patient's expressing some concerns about pain management. Labeling someone as a drug seeker really carries that stigma. And thinking about, how can we help this patient? What sort of services can we set them up with? And just knowing that, hopefully they don't want to be here. Our patients don't want to be in the hospital, and they end up with us because they have no other outlets. So is that easy? I'm sure me saying it right now, absolutely not, right? And is it easy for me? No. It's always uncomfortable to have these conversations. I do feel like every time I have them, maybe it gets a little bit better. But what we can sort of see from this slide is that, of course, being in our comfort zone feels great, right? We're comfortable there, everything's going well. But, once we start to kind of get out of that comfort zone, that's when the magic happens. And so that's when we can really make a difference in healthcare. We can make a difference to our patients. For those of us that are educators, we can teach this to our students. And hopefully when they're writing their nursing notes, instead of saying, the patient's complaining of 10 out of 10 pain, they got dilaudid, it's, the patient reported 10 out of 10 pain, they received dilaudid, pain decreased to 2 out of 10. So even though it's not easy, we do know that it is the right thing to do. So normalizing it is really, where we need to go with this. And as you can see, the elephant in the room, everyone may be thinking it, everyone, sort of having that conversation with themselves and their own brain. So it is the elephant in the room. So how can we normalize this? How can we sort of make this just part of our daily practice? And Alex, I think you're going to share this story, right?
Yeah. So I actually, I guess one thing I wanted to do was, first of all, put all my cards on the table. I've been teaching at the IHP for, I think I'm going on my third year. So I'm still, still, I would say, a relatively inexperienced educator, but, gaining experience. But that first year, I would say I learned a lot of lessons. I actually got to co-teach with Julika and Rachael, which was a lot of fun. I learned a ton. And honestly, a lot of what I've learned about fostering belonging in the classroom has been because of the two of you, and including just this concept of calling in. And I think it was my very first course that I was sort of like leading by myself. At the beginning of class, like our very first day, we talked about calling in, and we talked about the difference between calling out and calling in, and that, hey, like there are things that are worth calling out, but whenever possible, if there are things that we can do better, we invite you to call us in and help us learn. We really tried to create, I think, a space where we as teachers are also learning, right? That's really the bottom line here. And so basically invited students to email us or communicate with us whenever they felt necessary about just, if we were ever using language or just using behaviors that were making them feel anything other than welcomed and belonging in class. And I received this email from a student. I know it's a little bit hard to read, so I'm just going to read it through really fast because I know it might be hard to read on the screen. It says, "Hi, professors. During lecture today, I felt prompted to share a few inclusive language tips that acknowledge historical power dynamic issues in our culture. I've noticed that you all often use underserved communities, impoverished communities, or communities/persons of color to describe communities that are impacted by various health disparities and inequities. I'd like to suggest using historically and intentionally excluded communities or disinvested communities instead of underserved or impoverished. Using this language acknowledges that many of these communities have intentionally and systematically been denied and continue to be denied access to economic, political, and cultural resources and participation by white institutions. Moreover, using communities and persons of color is a bit unspecific and does not acknowledge that not all people of color are impacted by disparities equally. I recognize that some disparities are seen across all of the BIPOC communities categories, so I understand why in some cases it may be less desirable to list all the groups specifically, but to the degree possible, I would suggest specifying the type of subpopulation impacted. For example, if we're referring to higher rates of asthma in certain populations, we could specify that those higher rates are seen in Black/African American or Native/Indigenous communities. Specifying allows us to acknowledge that the burden of asthma is more prominent in these specific communities as opposed to all people of color, if and when applicable. And then you can see there's a resource linked there. Happy to chat more if needed. Thanks in advance for considering this information. So this was sent to me, it really was sent to all of us. You can see that we redacted all of the student information from the email, but this was after a lecture that I'd given, I believe. And you can imagine, if you can kind of put yourself in the shoes of the teachers for a second, not a comfortable email to get by any means, but a very gracious, very well constructed, very professional email, and just a profound example of calling in. This was clearly intended to inform and really help us to create a more inclusive learning environment. And our response to this, you can imagine after we get an email like this, we're going to talk about it before we respond to the student. And I remember Julika and Rachael and I getting together and thinking, like, what should we do here? Because this is more than just wanting to look good or sort of, do something with the optics. Like, we really want this to be a learning moment. And this is truly, like, I think we learned a lot from what the student had to say. And by the way, this particular student had a public health background. So this student was coming into nursing with, I believe, a master's in public health. So really, I think just had a lot of tremendous insight, and was also a student who identified as Black. So I think had a lot of intersectionality that was just really useful and helpful for us. So ultimately what we decided to do was we reached back out to the student and first of all thanked the student for being so gracious and willing to educate us. And what we did is we asked the student would if she would be willing we'd love to have like an impromptu discussion at the beginning of class to, first of all, address this, because that's the most important thing, right? Is to address, hey, maybe we're using language that is outdated or vague or just not making people feel welcome. So we should acknowledge that and atone for that. But at the same time, this is also a learning moment for everybody. And we basically reached out to the student, fully wanting to also acknowledge that this is a Black student who is doing a lot of invisible work already just by educating her teachers about this issue. So we very much, wanted to make it clear that this is not required, and if she doesn't feel comfortable doing this, we don't have to. But if she's willing and interested, we'd love to have an impromptu discussion at the beginning of class, and that's what we ended up doing. She was more than willing to do it, and we had I described it as it was almost like it was like a morning talk show. It was like we had two stools up at the front of the classroom. We both had microphones, and we just discussed what happened. And she delivered just a wonderful, very succinct and just very eloquent description of everything she said in this email. And it was really just a moment that I think has stuck with us, and just a beautiful example of calling in. And we wanted to share that with you.
Thank you. And now I'll talk a little bit about inclusive syllabus. So this will be a little bit of a, I think, like a synthesis of what Alex and Rachel have shared so far. So what is the official purpose of syllabus? I know that we all love our syllabi because we know that this is almost like a contract with our students, right? So we know that what we have in the syllabus is pretty much students have to adhere to, and it's very easy for us to say, well, you didn't do this or you didn't submit this on time, so it's in the syllabus, so now you can't really argue it. So it's a contract, it's a communication tool, it's a planning tool. So it's kind of like orientation to the class, right? And they're usually pretty long. Sometimes our syllabus is like 10, 15 pages long because we want to put everything in there to cover all of the areas of the class, so that we don't have quote unquote issues in the future with students, and we can just refer them to the syllabus. But when you think of it, syllabus is usually what the students see first. When we open a new class, I already have 2 classes that I'm going to be teaching this summer, and the students already want to know what the plan is, what is the schedule, because they're trying to plan their summer and when they can take their vacations and take off and plan their weekends. So they want to know the schedule, and usually the syllabus is the first thing that when I open the new class, there's usually nothing else there yet, but the syllabus is there with a tentative schedule, right? So it's their door to that new class. It's the first thing that they see. So when you think of it, right, you see that door, and then when you see it, which door would you choose? So you can either enter through this kind of door into my classroom, or you can enter through this kind of door. And then the syllabus is kind of the door. And now by reading the syllabus and getting yourself familiar with the syllabus, then you kind of have an idea of what to expect from the class. So you're kind of setting the tone of really what your class is going to be like for the students. So this is really what the unofficial purpose of the syllabus is. And we make every attempt, like Alex and Rachel both said, we've been teaching together for a while now, and it's always, I would say that for the past few years, it's either like me and Alex teaching together, or Alex and Rachel, or Rachel and myself, or sometimes all 3 of us. So we have worked together for quite some time, and we always try to make the syllabus very welcoming, very, very inclusive. We want the students to be comfortable. We want the students to feel like they can call us in, what Rachel was talking about. We use those inclusive language tips to make sure that students know that we also want them to be able to then go out and work with their future patients or patients in clinicals right now, and make their patients feel, welcome and included, and like they belong, right? So this is something that is definitely at the top of our I think goals and priorities for every class, to create that very welcoming and learning atmosphere. So some of the areas of our syllabus that help with that is the one is setting the stage. So all of our syllabi have this welcome message. And during that welcome message, we introduce ourselves, but we also share our identity, our background, our privilege. We also share our commitment to diversity and inclusion. We do actually talk about calling in our syllabus, and we say about how if we say something that is going to make somebody feel excluded or uncomfortable in any way, to please call us in and share it with us. We acknowledge that it's a mutually learning atmosphere. So we do share with our students that we learn from them as much as they learn from us. And we, as you, I think all know, our students come with it's a second career, sometimes a second degree program. So they come with a plethora of knowledge that they bring into this program. So it's actually very often that we do learn from them the same way that they learn from us. We already talked about inclusive language and inclusive terms. We also refrain from using jargons and abbreviations because sometimes they are just not clear to students. And I still remember I'm actually a pretty new nurse. It is true that it's my second career, and I have been out of school for about 15, 20 years before I went back to the nursing program. And when I remember in the first week of the program, our professors were using N/W on the slides, and I remember thinking like NV, and I'm like, what's NV? And I didn't know what it was, so I couldn't even focus on what they were talking about because I couldn't figure out this abbreviation. And it's just nausea, vomiting, right? But as a first semester nursing students, you don't know what that stands for. So it already took away from my learning because I was just trying to figure out what that NV, abbreviation was. And we also try to use very positive language and supportive language. So for example, instead of saying like, you'll fail this class if you receive this and this grade or something, or this is a failing grade, we use a passing grade. So, a passing grade is above this and this, instead of the failing grade is below this and that. And then another area of our syllabus is support and setting them up for success. So we have a lot of information about how they can get support, who they can reach out to. And we don't just say, oh, just go to academic support. We actually put names. We put email addresses, contact information. So they don't have to do the extra work. They don't have to search. They don't have to go to the website. It's pretty much all there. So we try to make it as easy and as accessible to them as possible. We also make sure that we give them information about the books, where they can access them, the hard copies. You know that the books are very expensive. And we want to make sure that they know that they have access to those books at the library. And we give them also information and contact information for the writing center. We also tell them that we are always available for them. Of course, just like Alex, I think, said in the beginning, that setting boundaries is important, or I think somebody actually said it during the Slido poll. Setting boundaries is very important. So of course, we don't want to say we're available 24 hours, 7 days a week, but it is also important for them to know that they can reach us and set up a one-to-one meeting if they need to, and that we are always available for that. So now we'll talk a little bit about how all of this that we just talked about translate to bedside nursing. And before we talk about it, we're going to do another quick skit. So the settings for this skit are going to be in the hospital. And this is going to be a shift pass-off report. So one of us is going to be a nurse finishing up the shift, and then another person is going to be the nurse starting their shift, and Alex is going to be a nursing student. I'm just going to change my background really quick.
We're back in the Zoom hospital now. And Alex has got his scrubs on. Love it.
Right.
Okay. Hi, Julika. I think we are taking report from you today.
Oh, hi. Yes, sorry. was so cold here last night. I don't know, the heat is always broken. Yeah, so you're taking room 214, is that correct?
I am, and I want to introduce to you, this is Alex Wolf. He is actually a student working with me. He's in his final practicum, so he's almost finished with nursing school.
Oh, okay. I'm just really surprised that they gave you this assignment with a student, because I don't know how much he's gonna learn, but I mean, if if he's okay with that, then that's fine with me. But anyway, so yeah, so you'll have Mr. R. He's a 89-year-old, just older guy. He's still full code. I don't really see the point of that, because it's my third night shift in a row, and honestly, he's been circling the drain for the past like couple of nights. So I'm pretty sure that we're going to be making him CMO shortly. The family was here all night. They are in denial. But there's really not much that we can do for him. He's like end stage heart failure, renal failure. I've been giving him PRN IV dilaudid all night, just around the clock. So he's not really responsive at this point. But again, still full code. Yeah, that's pretty much it. There's really not much to say. What was your name? Alexander.
Alex.
Anyway, so yeah, you won't be able to really do much. Just like turn him, keep him comfortable, and I guess you'll learn how to deal with a difficult family. But that's pretty much all I have for you. Sorry, I'm just like, this coffee is so weak that I need to get a better coffee machine here.
Oh, it sounds like you had a really
Do
difficult
you have any
shift.
other questions?
Let's see. I was just writing a few
Oh,
things
I'm
down.
sorry. I gotta catch a train. So are you guys okay? You can just
Okay.
read. You can just read. I mean, and again, not much to do there. So are you guys okay if I just split really quick?
Okay, all right, thanks,
All right,
Julika.
bye.
We could take over from here. So, okay, Alex, so I know, you likely haven't encountered a patient that's approaching the end of their life. So sort of how are you feeling right now after, after hearing that report?
Um, I, I don't know. I don't even really know what to say. I don't know. I guess it felt a little bit harsh to me. Yeah, I don't even. I mean, I guess I don't really know like what the plan is. Like, it sounds like the patient's heart failure is really bad. Um, I don't know, and I didn't know what I heard her say something about CMO and withdrawing care, and
Yep.
yeah, but then like the patient's full code, so I don't know. I guess I don't really know what's going on.
Yeah, no, those are some great observations that you picked up. So, I think we have a lot of work for us today. I think we definitely need to connect with the team and figure out a really, a plan that will, that the patient wants and their family members. So, a few things that came up, and these are things that we're trying to do some work on our unit, sort of about some of these terms, that are kind of embedded in our language. So I will talk to Julika, on the side at a different time, but I'm glad that you sort of picked up on some of those words like, they're only CMO, they're circling the drain. And the family is in denial, because those are some words, especially like the withdrawing care. If the family hears that, they may think that, we're taking away care, or we're not going to give them pain medications. But of course, we want to do what, of course, the patient wants and is what their, requests are. So we're going to work on all of this today. And yeah, hopefully by the end of the day, we'll have a better plan in place.
Sounds good.
Thank you.
Sorry, just turning my video back on. So hopefully you're able to, through this little skit, understand how much words matter that we use, and how much these words can lead to your own image of a patient, and how much they can lead to your implicit bias. And we wanted to follow it up with the mention of this study that was done, where this one was actually done for clinicians, but they did a similar study for also just people that have no clinical background, where they use the same the same description of a person, of a patient, but in one instance they use words such as substance abuser, and then in another instance they use substance use disorder, that the person has a substance use disorder instead of being a substance abuser. And that study showed that even just changing those two terms change the way that the people listening to it perceive that person, and that they were more likely to judge the person, and that the person, you know, in their eyes, that the person was more deserving of the blame and punishment if they called them a substance abuser versus a person with a substance use disorder. Rachel, do you want to take it
Yes,
from?
yeah. So just to sort of wrap things up, so we have a few minutes for questions. As you know, Julika said, words do matter. I think what we all sort of know is that most of the time, or hopefully most of the time, you know, we are not realizing a lot of these terms that we are using, and that it's so embedded in our language. You know, it just these words, you know, we use them, and then our newer nurses use them, and then it just sort of keeps getting passed down. Slide. So where do we go from here? You know, all of us here in this room, we are role models, whether we are educators working in the clinical setting, you know, whatever our role may be. So hopefully we can either make a commitment or, you know, continue our commitment to learning and growing from all of our mistakes. Okay, so I know there's a few announcements at the end, but we would love to take this opportunity for any questions, comments, thoughts. And hopefully we gave you a little bit of a laugh with our acting skills. Our students sometimes love it. Sometimes they think, oh, that's way too cheesy, but at least it gives them a little bit of the experience.
I thought the report skit was really powerful. You guys did a great job, and this has been very enlightening, and I will walk away so much more aware of what belonging and compassion means.
Thanks, Mary Beth. That was very kind of you.
Yeah.
Andra?
Indra?
I just want to say thank you so much for that. I mentioned to you all that I teach a social justice and population health course, and so much of this lives there. And you just have sort of planted some seeds about ways that we can take that and should be taking that across the curriculum, including, you know, clinical practice, but also I'm reminded of the intersection of language and trauma-informed care and trauma-informed educational practices. So, you know, and when we think about the population, you know, people, palliative care and end-of-life folks, how do we recognize, respond, and avoid re-traumatizing people? So those principles also apply for the students that are, but I really think you know, to your point in the beginning, that we're all still learning, and we can't clean that up until we have, you know, a raised consciousness ourselves around our own language. So thank you for planting all these seeds and the great examples and great acting.
We've had some practice.
You can probably tell we have a lot of fun with this, and yeah, my favorite is always when I will see Julika and Rachael, like they'll be like acting out a scene during class, and I'm just like walking by in the hall and I just see them doing this, and it's just my favorite thing in the world. It's just yeah.
You know, I use an anonymous display for students to put up examples of things they've heard in clinical, and the sad, really discouraging thing is that what you role modeled is very present and pervasive across settings. Still, we have a lot of work to do. We have a few more. I'm going to lower my hand. Anybody else have any comments or want to share?
This is Betty. Just to add, what a great presentation. I mean, these little things, like I loved your image of the door, but just the small things about language, I agree, can just change everything. And there were so many things that were great reminders to me for, you know, from what you've done. So great, great work.
Thank you.
I'm gonna take a kind of copy this idea of skits like that. It really kind of lightens it a bit, and gives another way to engage with these issues. So appreciate the skits. Can we give them a round of like applause, send them all our love for taking the time to share this with us. And thank you all for being here. Really quickly as we wrap up. Andrea, can you just pop in the chat the link to the faculty corner, just to let you all know that we have coming up on March 19th, and their online program and integration of palliative care education within that program, strategies for success and collaboration with them. So that's going to be really exciting, particularly for folks that are thinking about online application. And then finally, I would love to have Alex be a cheerleader for maybe those of you that might be interested in coming to our second faculty workshop in Portland in July. The applications are open and they're on that same website. And Andrea, I think, just put a flyer in the chat. This is a 2-day grant-funded workshop that if you can get yourself here, we're going to look at how do we take all these the concepts around palliative care education and teach them and integrate them into our program. So Alex, do you have any parting words?
I can't recommend it enough. First of all, for those of you who are interested in learning how to, first of all, what you need to implement, what you should be hoping to try to implement, in terms of the new essentials and palliative care's competencies into your curriculum, this is the place to do it. And not only is it the place to learn what to implement, but also how to do it. It was an amazing intensive on backwards design, competency-based education, and probably the most important part was just getting to meet an amazing group of peers from all across the country. Dan Weiss and I were suite mates there, and it was so much fun. It was so relaxed too. I mean, it's really just a great way to connect with like-minded people. I'm not gonna lie, I was nervous about doing it only because I live in Boston, and going to Portland, Oregon for 2 days, I was like, oh man, this is going to be hard. It was so worth it. I'm so glad I did it. I don't know if is it still going to be in the dorms, the housing?
They are, yes.
Oh,
so
that's great.
it's
It
really
was so
fun.
fun.
It's
It was
fun.
great.
We'll feed you. We'll give you a place to sleep in the dorm. So we're just going back to college.
And free registration.
Pardon?
And free
Registration.
registration.
Yes.
Yeah. And go ahead, Andrew. Sorry.
Applications are due April 1st. You can shoot myself or Dr. Lippy an email if you're interested in attending. This year we have funding to support 100 undergraduate faculty and 50 graduate faculty. So if your focus is graduate, please consider coming. Thank you, Melanie. All right, we're happy to answer any other questions, and if there are none,
I was just gonna add that instead of speed dating, we did speed poster presentations, and Alex and I were back to back since we're both near the end of the alphabet. Each presenter got somewhere between 2 and 2.5 minutes to present our posters displayed on a screen. It's amazing what you can cram in when you're concise, but there was also the little hook that pulled us off stage if we went over time. But you got to see what, 16 posters presentations in an hour, right? After feeding us nice hors d'oeuvres and adult beverages. It was a pretty cool way to do the poster presentations.
So please consider applying and joining us this summer. And with that, I think we'll, again, thank you to our presenters, and we'll see you all. Have a great, what is this, Tuesday? Have a great rest of your day. Bye, everyone.